Good afternoon, everyone. Thank you so much for joining us today for the Inpatient Rehabilitation Facility Quality Reporting Program Provider Training. My name is Glenna Davis, and I will be your host and moderator today. Slides 2 through 4 contain a reference list of acronyms that will be used throughout today's presentation. At this time, I will review a few housekeeping items. This webinar is being recorded. It will later be posted to the CMS Inpatient Rehabilitation Facility Quality Reporting Program website. We will provide you with details on accessing the recording via email when it is available. If you would like to use the closed captioning, there is a closed captioning window near the bottom of your screen. The phone lines will be on mute for the duration of the presentation. Due to the large number of attendees on today's webinar, we are unable to field questions over the phone, but you are able to submit questions electronically if you follow the instructions that we will discuss later on during the presentation. If you have a question at any point throughout today's presentation, please enter it in the form that we will walk you through. We will answer as many questions as possible during the presentation. Responses to all submitted questions will be published on the Inpatient Rehabilitation Facility Quality Reporting Program webpage. Also, an email will be sent to you when the Q&A document is available. Instructions for submitting questions are on slides 10 through 12 of the current slide deck, and we will review those instructions momentarily. If you would like to download today's presentation slide deck, click the Media Library icon located on the top right of your screen to access the shared files, and then click on the green arrow next to the file name in order to download the presentation. The presentation slide deck will also be posted, or is also posted, to the IRF QRP webpage. If you would like to display the slides in a larger view on your screen, click the title of the PowerPoint presentation and the option for full screen will appear. If you click on full screen, you will change your view only to be in full screen mode. To exit full screen, hit the escape key on your keyboard in order to return to normal view. During a portion of today's webinar, one of our speakers will be conducting a live demonstration of the reporting system. At that time, when the presenter shares her desktop in share screen mode, click on the Fit to Screen view to see the entire screen that is being shared. Throughout today's event, we will be using polling questions. Polling questions allow the speakers to ask questions to gauge your understanding of the material being presented. Each polling question will appear at the bottom of your screen. Review the answer choices offered and choose your answer. Use your mouse to click on the circle to the left of your response. There is no need to hit submit. Once you choose your answer, it will be automatically submitted for you. You can change your answer at any time before the poll is closed. Your answers are confidential and will only be reported in aggregate percentages. Now let's go ahead and test the polling function. Our first question today: how many people, including yourself, are participating in this webinar together? Please choose your answer choice. This is great. I see many answers coming in, and this is very nice to see. As you all can see, the polling function is fairly easy to use, and we look forward to your participation throughout today's event. Here's an example of the electronic question submission form and the process to use to submit questions during the webinar. To submit questions, visit the web page listed on this slide. I will also share the link in the chat box. By clicking on the link, a separate internet browser window will open. Once you get to the landing page, enter your name, organization, and email address. After you've entered your contact information, use the drop-down menu to select the section of today's presentation that your question refers to. Type your question in the following field, and then click Submit to send your question to the presenters. You may ask another question by clicking Submit Another Response after the page refreshes. Alternatively, in the lower left-hand corner of your screen, there is a Q&A window. You can submit your question there by entering your question and hitting the blue Ask button. Today's webinar was created specifically to enhance provider understanding of the IRF Quality Reporting Program. We will include a live demonstration to show you how to navigate the IRF QRP website and identify resources that can assist you. We will conclude the event with a question and answer session and finally a wrap-up. At this time, I would like to introduce today's speakers. Our first speaker is Karen Pryor-Palace. Ms. Pryor-Palace is a graduate of Central Connecticut State University, where she earned a BSN. She earned an MBA from Rensselaer Polytechnic Institute. Ms. Pryor-Palace has held various positions during her more than 30-year career, including nurse manager of an inpatient rehabilitation unit, prospective payment system coordinator, staff development instructor, and case manager. She is a certified case manager, a member of the American Case Manager Association, a member of the Connecticut chapter of ACMA, and a 2007 Nightingale Award winner for rehabilitation. Throughout her career, Ms. Pryor-Palace has created and delivered training and education to all levels of staff and patients. Currently, she is employed at Mount Sinai Rehabilitation Hospital, a 60-bed, freestanding inpatient rehabilitation hospital in Connecticut. She was instrumental in creating a team responsible for the functional satisfaction and financial outcomes of patients. Next, I will introduce Gina Waltos. Ms. Waltos is a certified occupational therapy assistant who has worked in acute rehabilitation at Mount Sinai Rehabilitation Hospital in Hartford, Connecticut since 2004. She has held many roles, including staff therapist, outcomes coordinator, and team leader for quality and outcomes. Prior to joining Mount Sinai, Ms. Waltos began her career in the skilled nursing home field as a therapist and program manager. She earned her associate degree from Manchester Community Technical College and a BS in Healthcare Administration from Charter Oak State College. Gina has provided extensive education and training on the completion of the FEM instrument, as well as successfully completing the staff credentialing process. Finally, I'd like to introduce Ann Deitch. Ms. Deitch is a Senior Research Public Health Analyst with RTI International. She is a certified rehabilitation registered nurse with a doctoral degree in epidemiology and community health. Ann works on a CMS contract to develop and maintain quality measures and serves as the lead for the IRF QRP and lead for the functional status measures. Ann also has an appointment as a clinical research scientist at the Shirley Ryan Ability Lab and is a research associate professor in the Department of Physical Medicine and Rehabilitation in Northwestern University's Feinberg School of Medicine. We're so very pleased to have such experienced and knowledgeable speakers present on today's webinar, and we really thank them for being here today. It is now my pleasure to turn the session over to Karen Palace. Karen, the floor is yours.
Thanks, Lena. Gina and I here in Wethersfield, Connecticut want to thank everyone also and welcome you all to the webinar this afternoon. We very much appreciate your taking the time to spend with us this afternoon. We know in these very busy times that we all have competing requests for our time, and we appreciate that you've chosen to spend the next couple of hours with us, so thank you. And before I go any further, I want to make sure we go over today's objectives. And at the completion of today's program, we hope that you will be able to identify the resources available to guide understanding of the Inpatient Rehabilitation Facility Quality Reporting Program, demonstrate an understanding of section-specific assessment items to correctly interpret and code the IRF-PAI version 1.4, and be able to discuss findings from data analysis on data submissions, including the new assessment items that went effective October 1st, 2016. Today's webinar will not focus on detailed discussion of Section GG. This content will be provided in a future training. Gina and I thought it might be helpful if we spent a few minutes providing a live demonstration of the IRF Quality Reporting website. For those of us who have been working in rehab a long time, we may be somewhat familiar with the website, but we know that there are some newer folks to the industry and want to make sure that everyone knows how easy it is to access these resources, and want to make sure that you know how rich and full of information they are. Before we go to the live demo, I do want to do a quick disclaimer, and that is that this presentation was current at the time it was published or uploaded onto the web. Medicare policy changes frequently, so links to the source documents have been provided within the document for your reference. This presentation was prepared as a service to the public and is not intended to grant rights or impose any obligations. This presentation may contain references or links to statutes, regulations, or other policy materials. The information provided is only intended to be a general summary. It is not intended to take the place of either the written law or regulations. We encourage readers and listeners to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their content. And with that said, let's go to the demo. So there are a couple of different ways in which you can access the quality reporting web page. And the way I like to do it is I just Google IRF QRP, that's one way, and you'll find it pops right up. You can see the address here in the top of the page, or you can do cms.gov. Any of these ways will quickly get to this page here, which we like to refer to as the landing page, as it's the first one you'll come to. You'll find that it's really easy to navigate through, and for those of you who do it all the time, I'm sure you agree with me, and for those of you who really haven't taken the time to do this, I encourage you to do so, because there's some terrific information here and it's very easy to get to. The first page really just describes the quality reporting page and what the program is all about. We're going to go to the left-hand side, and you can see Gina is going to click on Spotlights and Announcements. Gina, my friend here, is navigating for me while I focus on the content here. So thanks, Gina.
Oh, you're welcome.
So the Spotlight page is one of my favorites. It's one of the ones that I go to right away, because you can see very quickly that the updates are listed here and they're dated. So you always know where you left off the last time and what information is newly available to you. Here you can see August 11th, the training materials available for today's webinar was announced. If you scroll down slowly, you can see that it goes in descending order, all with dated information. So it's very easy to be able to see where you left off. The updates are posted at various time frames. You can see here one was July 13th and the other was July 18th. So there were 5 days in between that. But as we scroll down, you'll see that there's a different time period. So you may need to access the website a couple of different times during the month, or what I started to do probably about a year ago, I found that I was very well intended to go to the web page, but the day would get away from me and a meeting would pop up on my schedule. So I actually invited myself to a meeting. It's every Tuesday at 3 o'clock. Probably going to miss the meeting today because I'm here. But I would come to the web page and check out what's new. And I block off that time on my calendar so no one can schedule time for me, and I'm sure that I'm checking the site every single week. And that way it's very quick to do, and there's not much information I need to do. So if we scroll back up, we're going to go to the reporting measures information. And here's where you're going to find information related to the quality measure user manual, any measure specifications. You can see the National Quality Former Measure ID numbers, and as you scroll down, Gina, you can see it goes from most recent and goes down, and towards the bottom of every page you'll see that there are downloads, and those are available for you to print and use as you see fit. We're going to scroll back up and go to one of my favorite pages, and that's the Quality Reporting Manual. And here's where we can get our copies of the manual. Gina, if you scroll down, you can see. And what's great on the downloads here is you'll see the version 1.5 of the IRF-PAI and the 2.0. Those are here to be reviewed. I do want to stress that the focus of today's webinar is on the 1.4 version, since we'll continue to use that. But none of the quality indicator sections really have changed between the version of the 1.4 and the 1.5. The only change to the version 1.5 is the removal of the swallowing item. So this is a great resource for you. You can stay on top of everything. The technical information page may be something some of you may want to visit often, and on that page there's technical updates, contact for technical issues, and IRF-PAI submission information. The training page is, of course, our favorite. Here's where you're going to find, again, updates regarding the training of today's webinar, and if you scroll down, you can see history of other training sessions that have been provided. Some of them live and some of them via web. You can see here Gina's pointing to a YouTube video recording of one of the review and correct reports. So there's a lot of different ways in which you can stay current and educated. If you scroll down further, Gina, I want to show the history of some of the training. And for those of you who need to continue with that, it's here. You can click on Quick the IRF Training and then a zip drive here. And you can see all the presentations from the previous live training. So that's a great resource. We're going to head back. The public reporting is next, and that really is provides information on public reporting updates, resources, educational materials. And again, the downloads are down below, and you can find those. Just to briefly point out the frequently asked questions section, which is another place. We're not going to click on there due to time, but that's a great place where there's a number of different questions other folks have posed that you can go to and read those questions and find the answers. The data submission portion is another area in which you can go. Updates related to data collection, final submission, deadlines for fiscal year 2018, payment updates, those kinds of things. So from there, we're going to head back. So you can see how easy it is to get to, and we're going to just scroll through and get to the next slide. I apologize, a little bit of a switch. Okay. And the Federal Register is another area in which you can get some information. For those of you who've been in the industry a long time, you know that the proposed rules tend to come out in the spring and April, and final rules are released in August. And this is a great spot for you to gather some information. Okay, and if you also want to stay connected, you can receive mailing list notices and announcements. Also the open door forums, if you haven't participated in those, I would strongly recommend those. It's a great opportunity to have a dialogue with CMS. Want to quickly talk about the IRF Help Desks, and there are a number of them. Here is a table that shows, or a slide that shows the 6 provider help desks. This is a great resource. The next one is a very specific vendor-related help desk, and we're going to go through them quickly. So the IRF Quality Reporting Help Desk has an email here, and you can see the examples of the types of issues you want to present to them if you have questions. And after we've gone through the help desk, the various help desks, if you're not sure where to send a question, you can always send it to these guys, and they're more than willing to triage your question for you. The CDC or NHSN Help Desk has an email address here as well, and the examples of the type of issues you may want to present to them are catheter-associated urinary tract infection questions, C. difficile questions, and any enrollment and reporting for the National Healthcare Safety Network. Data submission and data validation help desk. Here you have both a help desk email and also a phone number. So you can choose between the two depending upon whether you want to have a dialogue or whether you'd like the answer emailed back to you. And you can see the type of issues that they handle here, and they're a wonderful resource for everyone as well. The IRF Public Reporting Help Desk has an email. And you can present questions to them that are related to reporting periods for the CASPER review and correct reports. Measure included the provider preview reports, IRF Compare website, data, IRF data available on the data, Medicare.gov. And here's one that we use. It's the Clinical Items Help Desk. Here you have both email, and a phone number, and we kind of go back and forth, Gene and I, between which we use. Sometimes I like to email a question, and then I can print out that email and put the response in that section of my training manual. So if I have that same question again in a couple of months, I know what the answer is. Or other times I like to give them a call and be able to kind of talk back and forth a little bit about what my question is and dialogue back and forth and clarify if I think it's a question that may have follow-up questions. Here are the examples of the types of things we may ask about medical information, functional modifiers in the FIM, discharge information, ID information, and payer information. The IRF Medicare Policy Help Desk has an email here, and here's the type of questions that they tend to handle, and that's the IRF Medicare reimbursement, any claims or billing questions you might have. If you have questions about eligibility or coverage requirements, therapy information reporting, and IRF-PAI requirements for the non-quality sections. As I mentioned before, the vendors have their own help desk, and they have questions that are more unique to them than the providers, and so they are given their own help desk. It is an email that they can access here, and the issues that are presented to this group of helpful people is the IRF-PAI data technical specifications or validation utility tool, software, whether it meets software and CMS requirements, technical questions that are related to the IRF-PAI data specifications as well. So these folks are really helpful. I encourage you to call them or email them. Their goal is to really clarify things for us, and we really should use them. Okay, so we have a little bit of a polling question here. We're curious to know how often people use the IRF quality reporting program web page on the CMS website. Are you somebody who very frequently accesses it, like I do every week? Are you someone who occasionally uses it, maybe monthly? Do you rarely use it, which would be selection C? Or can you say that at this point you've never used it, but of course after today you're going to? So we're waiting to see how people respond. They're always interesting to see. Okay. Give people another couple minutes. Remember, there's no wrong answer. Terrific. So it looks like for the most part, 50% of the folks say that they occasionally access it monthly. So that's great. It's good to see that people are using it. I would, again, encourage you to access it more often. It's very empowering. The more information we have, the more prepared we are for any changes that come down the way. So I would definitely encourage it. We'll do a quick knowledge check. Let's see how I did explaining this information to you. Which resource below is the best reference for guidance in coding the IRF-PAI assessment item? Is it A, the IRF-PAI training manual? Is it B, the IRF-PAI change table? Or is it C, the QIES user maintenance application user guide? Wow, people are answering as I speak, so that's very great. And it looks like 100% of the folks who answered said the IRF-PAI training manual, so terrific. That's exactly right. We got one more for you. If you have a question about coding an unstageable pressure ulcer on the IRF-PAI, which help desk should you contact? Would it be A, the IRF Medicare policy, B, the CDC NHSN, C, the IRF Quality Reporting Program, or D, data submission and data validation? Wow, this is a very smart group of people listening in. So it looks like 97% of the folks answered correctly, and that is C, the IRF Quality Reporting Program. Terrific. So now I'm going to turn things over to Ann. Ann, take it away.
Great. Thank you so much, Karen. Now we'll review some aspects of coding the IRF-PAI that have been submitted to the IRF QRP Help Desk. On the next slide, you'll see the first topic I wanted to cover was dash use. In general, CMS expects dash use to be a rare occurrence. There are two instances where coding the dash does not impact the annual performance update determination, that is the APU determination. The first instance is related to coding goals, and the second instance is related to coding of the brief interview for mental status. I will review these two instances on the next two slides. So first of all, on slide 54, you'll see that section GG includes self-care and mobility items addressing patients' performance and goals. Goals may be coded using the 6-point rating scale. At least one goal must be reported for one of the self-care or mobility items. If goals are not reported for one or more items in goals, then a dash may be used to indicate in the box for goal. Using a dash in this instance does not affect APU determination, and again, as long as one goal is reported. The second instance that I wanted to describe relates to the brief interview for mental status, or the BIMS. So use of a dash to indicate that the interview has stopped is an acceptable use. If a patient refuses to answer the questions in C0200 and C0300, then coding a dash for the C0400 items does not affect APU determination. If the interview is stopped, please code the C0500 item as 99 and code C0600 as 1, indicating yes, and then check all that apply for C0900. The next topic I'd like to cover is related to checkbox items. So there are several on the IRF-PAI. For example, in section I, there are several items, a list of medical issues. If a patient does not have a medical condition, please leave the box unchecked. Do not enter a dash if you know the patient does not have the condition. You may leave that box unchecked. Also, on slide 57, in section O, there's also another checkbox item. Again, if the patient does not use total parenteral nutrition, you would not check the item. Please do not enter a dash in the box if the patient does not use TPN. On the next few slides, I just wanted to cover important time frames. So as you know, there is a 3-day assessment period, and that refers to 3 calendar days. The admission assessment period refers to the day of admission and the 2 days following the day of admission, ending at 11:59 p.m. The discharge assessment period refers to the day of discharge and the 2 days prior to the day of discharge. On the next slide, you'll see we have 2 other items that have time frames that are also important to review. So history of falls, which is J1750, refers to falls or a fall with major injury that happened during the past year. In item J200, prior surgery, the time frame there is 100 days, and that refers to the 100 days prior to the day of admission to the IRF. Now we have some knowledge checks, and I see the questions have come up. And so the question here is, if at least one self-care or mobility goal is entered on the IRF-PAI, using a dash for the remaining discharge goal items will not affect the APU determination. Is that true or is that false? Looks like most people are correctly saying that that is true, and again, that is correct. Okay, moving to the next second knowledge check, number 4. Leaving an item unchecked is an allowable response for which of the following assessment items below? Option A would be the MO300A stage 1, pressure ulcers. B, section I, 2900, diabetes, mellitus. C, GG0170G2, car transfers, discharge goal. And D, H0350, bladder continence. I see that most people are coding option B, which is the correct response. Diabetes is one of the check boxes. With that, I'm going to turn it over to Gina, who will begin the discussion about the specific items on the IRF-PAI.
Thank you, Anne. Good afternoon, and thank you for joining me. We are now going to review Section B, Hearing, Speech, and Vision. Section B includes BB0700, Expression of Ideas and Wants, and BB0800, Understanding Verbal Content. This section is addressed on admission. In this section, we are coding the patient's ability to communicate with others and understand verbal content in their primary language. Modes of communication can include verbal, written, sign language, gestures, or a combination of these modes. As you can see here, this is a screenshot of BB0700. The coding for this section is based on a 4-point scale, and you would enter the code that best reflects the patient's ability to express their ideas and wants. A code 4, the patient expresses without difficulty and their speech is clear and easy to understand. A code 3, the patient expresses with some difficulty, which may include difficulty with some words or finishing thoughts, or their speech may not be clear. A code 2, the patient frequently exhibits difficulty with expression of needs and ideas. And a code 1, the patient rarely or never expresses self, or if speech is very difficult to understand. A code 4 states that a patient is able to express complex messages without difficulty. Complex messages include discussions about medications, discharge planning, and caregiver issues. Here is a screenshot for BB0800. The coding for this section is based again on a 4-point scale, and you would enter the code that best reflects the patient's ability to understand verbal content. The 4 different codes are as follows. A code 4, the patient understands and has clear comprehension without cues or repetition. A code 3, the patient usually understands most conversations but misses some part or intent of the message or requires cues at times to understand. A code 2, the patient sometimes understands. With this code, the patient understands only basic conversations or simple, direct phrases, or if the patient frequently requires cues to understand. A code 1, the patient rarely or never understands conversations. A question that was frequently asked in previous trainings is to clarify the difference between a code 3 and a code 2. The difference between coding a 2, sometimes understands, and a 3, usually understands, is based on the frequency of the difficulty the patient has understanding complex conversations. A code 3 would be used if the patient is able to understand most questions, speech might be slightly unclear, or may require cues at times to understand. A code 2 would be used if the patient only understands basic conversation, requires frequent cueing to understand, or displays frequent difficulty expressing their ideas and wants. It is important to observe the patient's interactions with other people in various locations and with different circumstances. Clinicians of different shifts, as well as family members, can be queried. We are now going to move on to Section C, Brief Interview for Mental Status, also known as the BIMS. The BIMS consists of 3 components: repetition of 3 words, temporal orientation, and recall. The results of the 3 components are totaled into a summary score, which is item C0500. The following are the instructions on how to code the BIMS. An interview should be conducted on any patient not screened out by item C0100. If the patient rarely or never understands, cannot respond verbally or in writing, or an interpreter is needed but not available, you would skip to C0900, memory recall ability. Once you have determined that the interview should take place, it would be best to conduct the interview in a private setting. Be sure the patient can hear you and position yourself so that the patient can see your face. Patients with hearing impairments should be tested using their usual communication devices and techniques as applicable. Try an external assisted device, such as headphones or a hearing amplifier, if you have any doubt about their hearing ability. And you also want to minimize background noises. It's a good idea to give a brief introduction prior to interviewing the patient. You could say something like, I would like to ask you some questions. We ask everyone these same questions. This will help us to provide you with better care. Some of these questions may seem very easy, while others may be more difficult. There may be some patients that express concerns as to why you are asking these questions, and they may feel more comfortable if you clarify that you ask these questions to all patients so that you can make sure that their care is meeting their needs. It is important to note that the interview needs to be conducted in one sitting and in the order provided. If a patient chooses not to answer an item, accept the refusal and move on to the next question. At times, a patient may respond with a nonsensical response. A nonsensical response is any response that is unrelated, incomprehensible, or incoherent. The response is not informative with respect to the item being rated. Any nonsensical responses should be coded as a 0. Here is a screenshot for item C0200, repetition of 3 words. For this item, you code the maximum number of words that a patient was able to correctly repeat on the first attempt only. If a patient is unable to correctly repeat any of the words on the first attempt, a 0 would be entered. The following are the coding tips for C0200. The words may be recalled in any order and in any context. For example, if the patient states, I think the first word was bed, that would count because bed was used in the sentence. You only score the number of words repeated on the first attempt. If the staff member conducting the interview cannot say the words clearly, have another staff member conduct the interview. For temporal orientation, you are assessing the patient's ability to report the correct year, month, and day of the week. To keep the interview flowing, it may be helpful to write the patient's responses to the month in the margin and then go back later and count the days if you are unsure whether the date given is within 5 days. If a patient does not answer the questions, you would enter a 0 in the box. Next, we're going to discuss the steps for completing section C0400 recall, and this is a screenshot of that section. To begin, you're going to ask the patient the following. Let's go back to the earlier question. What were those 3 words that I asked you to repeat? It is important to read the question as it appears on the IRF-PAI. The patient is allowed 5 seconds to spontaneously recall each word. For any word that is not correctly recalled after 5 seconds, provide a category cue. For further clarification on this, you can refer to Steps for Assessment on page C7 for the definition of a category cue. Category cues should be used only after the patient is unable to recall 1 or more of the 3 words. Again, you want to allow 5 seconds after category cueing for each missed word to be recalled. There are circumstances in which you may need to stop the BIMS interview. If after completing day of the week, all responses are nonsensical, there is no verbal or written responses to any of the questions up to this point, or a combination of no written or verbal responses and nonsensical responses has occurred, then it is acceptable to stop the interview. In the event that the interview is stopped, you would do the following. Code a dash for C0400, A, B, and C. Code C0500, which is a summary score with a 99. In C0600, should the staff assessment for mental status be conducted, you would code 1, yes. Finally, you would complete the staff assessment for mental status, C0900, memory, recall, and ability. It is important to note that the use of a dash in this circumstance does not impact APU determination. It is appropriate to administer the BIMS in written format if the patient's primary mode of communication is written and should be limited to this circumstance. Please refer to pages C19 and C20, Guidance for Completing BIMS Using Alternative Methods, in the Guidance Manual. In the event you have a patient that has an interrupted stay and is transferred to an acute care facility and returns to the IRF within 3 calendar days, the BIMS assessment that was conducted when the patient was first admitted to the IRF and prior to the program interruption would be the patient's BIM assessment. No additional BIMS assessments are required for interrupted stays. If the BIMS interview should have been attempted, but was not, you would code Section C as follows. For C0100, should BIMS have been conducted, enter code 1 or yes. Enter a dash for the following BIMS items: C0200, C0300 A through C, C0400 A through C. For the BIMS summary score, C0500, score 99, and for C0600, code 1 or yes. Finally, you're going to complete C0900, staff assessment for mental status. Please note that coding one or more of these items with a dash could impact your quality measure score. Finally, you can visit the CMS YouTube channel to view a BIMS video and other videos for interviewing techniques. This is a great resource to use when training new staff or to use as a refresher. I am now going to turn the floor over to Karen, who will discuss Section H.
Thanks, Gina. Nice job. Okay, as you all know by now, almost a full year into the reporting, because we started back October 1st, 2016, that the intent of Section H and the items in this section is to gather information on bowel and bladder continence. Bladder incontinence, as we know, can interfere with a patient's ability and desire to participate in any of the activities that they enjoy. It can lead a patient to be socially isolated, to develop some skin breakdown. We see urinary tract infections, and we all know that increased risk for falling. By identifying the incontinence, we can, in some of the situations, treat the underlying cause and hopefully prevent some of these effects. Before we begin coding any of these items, I want to remind everyone of the definition of incontinence, and this definition can be found in your training manual. Coding in Section H is done on admission only, and as Anne reminded us, is completed during the 3-day assessment period. Keeping in mind that this definition is different from others that we score on the IRF-PAI related to accidents. And the incontinence definition is an involuntary loss of urine when there is a loss of control of the evacuation of urine from the bladder, regardless of whether clothing or linens are soiled. Here's a screenshot of item H0350, and here you can see we have 7 coding options. You will be expected to select the most appropriate code for each patient using the 3-day assessment period. And for those of us who do this all the time, this looks real familiar. The codes are as follows. Code 0 is always continent. A code 1 is stress incontinence only. Code 2 is incontinent less than daily. Code 3 is incontinent daily. Code 4 is always incontinent. Code 5 is no urinary output for renal patients, let's say. And Code 9 is not applicable for indwelling catheters. So let's talk for a minute about stress incontinence. Some questions have been raised following the training in Dallas and Chicago, and we want to take a few minutes right now to clarify those questions. The definition of stress incontinence is included in this slide and should help determine if your patient has incontinence that is related to the stress of coughing, sneezing, laughing, lifting heavy objects, or exercise. In stress incontinence, typically only a small amount of urine is leaked, and only during or following these situations. Stress incontinence is very different from the type of incontinence where there is an involuntary loss of a much larger volume of urine and that is not necessarily following any one of these particular events. For further clarification, there does not need to be a physician diagnosis, and that question has come up a couple of different times. Based on the clinician's assessment, patient or family reporting, it could be in physician documentation, a patient can be coded a 1, stress incontinence only. Staff observations will be helpful in distinguishing whether incontinence is a large volume or a small volume associated to stress. Again, reminding everyone that for coding item H0350, it is a 3-day assessment period only. You're going to want to review all documentation and discuss with staff to determine the frequency. If intermittent catheterization is used to drain the bladder, code any incontinence levels that occur between the catheterizations. So for us in our facility, we do intermittent straight caths pretty often with a lot of our patients. We have a pretty robust stroke program. We have multiple sclerosis center of excellence, and we also take spinal cord injury patients. So during those first 3 days, we very often will do intermittent catheterization, and we may begin with, let's say, a Q6 hour, just to kind of get a sense of how the patient's bladder fills and how often. And sometimes the patient will be incontinent in between those episodes. We're going to change our care plan, and we're going to cath them more often, but we're going to have to count those incontinent episodes during that 3-day assessment period. Another question that came up in some of the trainings, the live trainings, had to do with behavioral patients. So if a patient is continent, but due to behavioral issues, purposefully voids on the floor, this is not considered an incontinent episode. And if we go back to the definition of incontinence that we are to use here, it talks about an involuntary release. And clearly, in this situation, it's quite voluntary. If the patient has an indwelling catheter upon admission and the device is removed on the 2nd day of the stay, and the patient has 2 incontinent episodes during that 3-day assessment period, you're going to code the patient as a code 2 that they are incontinent less than daily. You can only assess incontinence when the device is removed, and therefore if the patient has the catheter on admission removed on day 2, we would only refer to the 2 days in which they are incontinent after that. So let's move on to item H0400, which has to do with bowel incontinence. And here you can also see the options. Here we only have 5 options in comparison to the urine, which we have 7 options. But they are always continent, a 1 is occasionally incontinent, 2 refers to frequently incontinent, 2 or more, always incontinent, where there's no episodes of continence, and 9 is not rated. Maybe the patient had an ostomy. Being continent has to do with the ability to voluntarily release stool into a commode, toilet, or bedpan, or as the result of a planned bowel movement or part of a bowel program. Patients who require to maintain the passage of stool via artificial initiation, those of us know either manual stimulation or digital stimulation, rectal suppositories or enemas, would be considered continent of bowel as long as the result of releasing the stool occurred in a reasonable amount of time. Again, we want to talk a little bit about incontinence, and the cause of the incontinence really is irrelevant. So if the incontinence is precipitated by loose stools or diarrhea from any cause, including laxatives that potentially we provided, we would still need to count the patient as incontinent. And again, similar to the intermittent straight cath example I gave, during those first 3 days, sometimes as we're getting to know our patients and we're developing bowel programs, it's really, all you rehab nurses out there know exactly what I'm talking about. It takes a little while to really get that right combination of medications. And so sometimes we overreach and maybe provide a little more medication than is needed. This scenario was raised at one of the live trainings. It was in Dallas, and it was raised by an occupational therapist who bravely came up to the microphone, and I remember her well. And she talked a little bit about, her question was about the release of bowels in the bed for patients who potentially have a spinal cord. And her concern was that they have a large spinal cord population at the facility in which she worked, and that sometimes the para or quadriplegic patients that they treat are unable, for a variety of reasons, to get up onto a bedpan or commode for a period of time, whether they're concerned about skin breakdown or discomfort, pain, all those kinds of things. Maybe their blood pressure doesn't allow them to be upright quite yet. So her question was, if the patient has a bowel program that's been developed and is successfully done, but is released into a chuck rather than a toilet or bedpan, is that considered a continent episode? And the answer is yes, it is. As long as the episode occurs soon after the bowel program has been initiated. If that same patient, hours later, had an incontinent episode while in the bed, not following the bowel program, we would have to code that particular episode as an incontinent episode. It was a great question, and I always appreciated that she had the nerve to go to the microphone and ask it. We're going to do a quick knowledge check here, and here's a chance for you guys to participate again. So listen up. In this scenario, Mrs. B usually has stress incontinence. During the 3-day assessment period, she experienced a large amount of urine leakage daily. How would you code Mrs. B for item H0350? Are you going to code her a 0 that she's always continent? Are you going to select a code 1, which is choice B, stress incontinence only? How about C, code 2, incontinent less than daily? Or are you going to select code 3, which is D, incontinent daily? The correct answer is incontinent daily, and it looks like we had 96% of the folks answer that. So hopefully we did explain the difference between stress incontinence and incontinence, and I appreciate very much you guys participating. It makes me feel good that I got that concept across. So thanks so much. We're going to go on to another question, and this is knowledge check number 6. And in this scenario, Mr. T has an indwelling catheter in place during day 1 of the assessment period. On day 2, being the wonderful IRF that you are, you remove the catheter because you know that that's best for the patient. Mr. T, unfortunately, is incontinent during those next 2 days of his assessment period. How would you code H0350? Are you going to code 1, stress incontinence? Are you going to code 2, incontinent less than daily? Are you going to select 3, which is incontinent daily? Or how about D, not applicable? Give people a few minutes to answer up. Okay, numbers are still coming in. All right, it looks like folks did pretty well. In this particular, the correct answer would be coded as a 2, incontinent less than daily. And there were some responses that were incontinent daily, so let's kind of go over that a little bit again. So the rationale for why the correct answer is 2 is that the patient was incontinent only on days 2 and days 3 of that assessment period. The patient cannot be considered incontinent on day 1 due to the use of an indwelling catheter. That was kind of a tricky one, so I appreciate everyone participating. These are great examples to bring back to your facilities and share with the other folks on your team. They're great test questions for competency as well. So now I'm going to turn things over to Gina, who's going to talk to us about falls.
Thanks, Karen. So now we're going to go on to section J, and we're going to talk about falls. In previous trainings, the definition of falls and intercepted falls was a hot topic for IRF. For quality reporting purposes, the definition of a fall is the unintentional change in a position, coming to rest on the ground, floor, or onto the next lower surface. This can include a bed, chair, or bedside mat. The fall may be witnessed, reported by an observer, self-reported by a patient, or identified when a patient is found on the floor or ground. It is important to note that a fall is not the result of an overwhelming external force. For example, if a patient pushes another patient. An intercepted fall is considered a fall. An intercepted fall occurs when a patient would have fallen if he or she had not caught him or herself or had not been intercepted by another person. There have been numerous questions in regards to the definition of fall, and CMS has provided the above statement that they recognize that challenging a patient's balance and providing training on how to recover from a loss of balance is an intentional and important therapeutic intervention. Anticipated losses of balance during a supervised therapeutic intervention are not considered an intercepted fall. For items J1800 and J1900, the intent is to maximize patient safety and capture events that represent threats to patient safety. Only falls with major injury are used in the calculation of the quality measure, application of % of residents experiencing one or more falls with major injury. Item J1750, history of falls, is completed on admission, and the steps for assessment are as follows. Indicate whether the patient has had 2 or more falls or any falls with injury in the past year. To gather this information, you can interview the patient if he or she is capable of reliably reporting fall history, or, if appropriate, speak with family members or significant others to obtain fall history. Here is a screenshot for item J1750 with coding instructions. Again, this is completed at the time of admission. Items J1800, any fall since admission, and J1900, number of falls since admission, are completed at discharge. To gather this information, you can, but are not limited to, reviewing the medical record, querying staff including physicians, nursing, therapy, and nurses' assistants, review incident reports or databases, or review fall logs. Each facility is unique in how they keep track of falls, so these are just a few examples. Any fall since admission is completed at time of discharge. If the patient has not had any falls, you would enter a 0 and skip to M0210, unhealed pressure ulcers. If the patient has sustained a fall, enter a 1 and continue to J1900, number of falls since admission. Number of falls since admission is again coded at discharge only. You will need to determine the number of falls that have occurred since admission for the patient. Once that has been determined, code the level of fall-related injury for each. Each fall is coded once, even if the patient has multiple injuries from a single fall. You're going to code the fall for highest level of injury. For example, if your patient had one fall that resulted in multiple bruises as well as a subdural hematoma, you would record a 1 in item C, major injury. Injury related to a fall is defined as any documented injury that occurred as a result or was recognized within a short period of time after the fall and is attributed to the fall. Here on this slide you can see a list of examples of injuries and example of major injuries. Examples of injuries include skin tears, abrasions, lacerations, superficial bruises, hematomas, sprains, or any fall-related injuries that cause the patient to complain of pain. Examples of major injuries include bone fractures, joint dislocations, closed head injuries, altered consciousness, or subdural hematomas. We're now going to move on and do a knowledge check. Your scenario is, Mr. S has been working with his physical therapist on high-level balance activities. Today during therapy, Mr. S was asked to stand on one leg to challenge his balance. Mr. S leaned to the left, requiring the therapist to provide him support and to right him. How would you code J1800, any fall since admission? Would you code it A, 0, no, or would you code it 1, yes? So I'm going to give you a quick minute to let the results come in, and it looks like the majority of people are saying no, this would not be considered a fall at 98%. And that is correct. J1800 would be coded 0, no. The rationale behind this is because the patient was participating in a therapy session and his balance was being challenged in order to improve his mobility. Again, remember that challenging the patient's balance was part of the treatment session, and it was expected that the patient might need assistance to maintain his balance. Okay, now we're going to do another knowledge check. Your scenario is Mrs. G was working on stair training with the physical therapist. While Mrs. G was descending the stairs, her left knee gave out, requiring her to be lowered to the bottom step by the therapist. Mrs. G sustained a small superficial bruise on her elbow because she bumped it as she was lowered down. How would you code J1800, any fall since admission? Would you code it a 0, no, or would you code it a 1, yes? Okay, looks like the answers are coming in. All right, so let's see. 99% of you said that yes, this would be coded as a fall. And you are correct. J1800 would be coded 1, yes. And the rationale is because the patient was lowered to the bottom step by the therapist, and an unintentional change in position coming to rest on the lower surface is considered a fall. So now let's think ahead. How would you code J1900, number of falls since admission? This one is not a knowledge check or a polling question, so think about that for a minute, and we'll move on and get the correct answer. So you would code J1900 as follows. A, no injury would be coded a 0. B, injury except major, you'd place a 1 in the box. And major injury would be coded as 0, none. The rationale is because the patient sustained a small superficial bruise on her elbow, and this is considered an injury. We're going to do one final knowledge check. Mr. K has limited use of his left side and a left lateral lean due to a stroke. During a therapy session, Mr. K was standing at the parallel bars with the assistance of a therapist who was standing on his left side. Mr. K was using a mirror to help him monitor his balance. Mr. K began to lean heavily to his left side and was bearing some of his weight on the therapist as he attempted to right himself. How would you code J1800, any falls since admission? And you guys are really quick getting these answers in. And right now we have 100% saying that they would code this scenario as a no, which would be a 0. And you are correct. J1800 would be coded 0, no. Mr. K was in a therapeutic session working on his balance and posture. The therapist was aware that he might lift to the left and anticipated that he would require support to not fall. I'm now going to turn the floor over to Karen, who will discuss Section M.
Thanks, Gina. And I should say that Gina has done a tremendous job at our facility. She's one of our safety coaches. She runs Safety Huddle in the morning, and we have seen a decline in the number of falls we have, and she's just such a wonderful resource for us.
Thanks, Karen.
So we're going to go on to Section M, and before I do so, we've been going at it for about an hour. If you need to stand up or move, that's fine. I do not want anyone developing a pressure ulcer while we talk about Section M. So if you need to wiggle around, go ahead. So, Section M, always important to remind folks of the intent of the section. It's to document the presence and appearance of any change in the status of pressure ulcers. And it's also very important to point out, we want you to use this definition when you're assessing pressure ulcers related to the quality reporting items on the IRF-PAI 1.4. There are a number of different definitions out there, and we want to make sure that you use the one that's in your training manual. And here it is. It is a localized injury to the skin and/or underlying tissue, usually over a bony prominence, as a result of pressure or presence in combination with shearing and/or friction. The Section M items are coded both at admission and discharge. However, not every item is the same on admission and discharge. For those of us who participate in the completion of the IRF 1.4 version, we all know that the assessment piece begins on page 11, and the discharge piece starts on page 15 and goes to page 17. And here you can see an example of the admission assessment M0300A1-G1 is an admission assessment item, and the discharge assessment items have also that question, but also an additional G2 question. So there's additional information that's provided at discharge. So let's talk about the items. One of the concerns that's been raised is clarification about present on admission. And so the present on admission items M0300A2-G2 are coded at discharge, and that's the example I showed you on the previous slide. And the purpose is to address whether the pressure ulcer observed at discharge were either one, present on admission, or was it acquired or worsened during the stay. So let's make sure we're answering those questions correctly. A pressure ulcer that's reported at discharge and coded as not present on admission on the discharge assessment would be interpreted as a new or worsened ulcer. Conversely, a pressure ulcer reported at discharge and coded as present on admission on the discharge assessment would not be considered new or worsened. So that seems straightforward. But let's look at a couple of examples. So here in this slide, you can see on admission, you admit a patient with a stage 2 pressure ulcer. At the time of discharge, however, that stage 2 pressure ulcer becomes unstageable, and that's due to slough and eschar that is visible in the ulcer. In this example, this pressure ulcer was not present on admission. It has worsened. What we've done here is put side by side the admission assessment items alongside the discharge assessment items. Now, for those of you who use the IRF-PAI all the time, you know this isn't exactly how it's presented on the IRF-PAI. They're on different pages. But for comparison, we thought it would be helpful to put the items side by side. In this example, the number of stage 2 pressure ulcers on admission is a 1. At discharge, it's a 0. The number of these stage 2 pressure ulcers that were present on admission, we skip at discharge. The number of unstageable pressure ulcers due to coverage of wound bed slough or eschar at discharge is now a 1. And you can see at the bottom, M800E, worsening in pressure ulcer status since admission, unstageable, is now 1. So let's talk a little bit about why that is. At first glance, you might think that the pressure ulcer was on admission. So a stage 2 pressure ulcer, by definition, does not include slough or eschar, as those are signs that the wound is deepening and has more tissue involvement. And even though we can't stage this ulcer, what we can say is that it has now worsened, because clinically, a stage 2 just doesn't have slough and eschar. So we know it has worsened. The unstageable ulcer due to slough and eschar would not be coded as present on admission at the time of discharge because the ulcer was observed at admission as a stage 2, not an unstageable. Therefore, this pressure ulcer would be reported as worsened in the M0800E. Let's try another, what looks on face value a similar example, but it actually codes out differently. So say you admit a patient with a stage 3 pressure ulcer. That same stage 3 pressure ulcer also becomes unstageable due to slough and eschar by the time of discharge. In this particular scenario, the pressure ulcer was present on admission. It is not considered worsened. Again, let's put these items side by side and look at why we coded this way. In this example, the number of pressure ulcers on admission is 1, and at discharge it is 0. If we skip to 0300F1, the number of unstageable pressure ulcers due to coverage of the wound bed by slough or eschar at discharge is a 1. That's stage 3, is now covered with slough and eschar. The number of these unstageable pressure ulcers that were present on admission is a 1 in this particular case, and items B and E would be 0. So why is this different than the example we just provided? Although we cannot not observe the tissues to differentiate between a stage 3 and a stage 4, we do know that stage 3 pressure ulcers can have slough and eschar. So without the ability to visualize the tissues, we really can't say that it's worsened. It could be a 3 or it could be a 4. And so for this reason, this is why we code it differently than the first scenario. It should be noted that clinicians should always ensure that the ulcer is as clean as possible and debrided if possible or necessary prior to staging the ulcer before we simply just identify them as unstageable. Visualization of the wound bed is necessary for accurate staging. We know that. And pressure ulcers that have eschar or slough, such as pressure ulcers that have eschar or slough tissue present, such that anatomical depth of the soft tissue damage can't be visualized or palpated, should be classified as unstageable. These definitions are all available to you in the training manual and should be referred, as well as all the staging of the ulcers. What about if the wound bed is only partially covered? What do we do in those circumstances? Well, if you are able to visualize a portion of the wound bed and are able to stage it, then you are expected to stage it rather than just call it an unstageable. Any known pressure ulcers covered by non-removable dressings or devices should also be coded as unstageable. And what do we mean by known? What do we mean that it's a known pressure ulcer? And that is, it refers to when there's documentation that's available that says a pressure ulcer exists under that non-removable surgical dressing. So let's look at another scenario. This time, this is just for learning. We don't expect you to call in or poll in, so you can relax a little bit here. A patient is admitted to an IRF with an unstageable pressure ulcer. During the patient's stay, the pressure ulcer opens up and is reassessed as a stage 3. At discharge, the pressure ulcer is healed. This is a really good IRF. There are no other pressure ulcers. How would you code this item at discharge? In this particular scenario, for M0210, unhealed pressure ulcers, it's a 0. For M0900C, healed stage 3 pressure ulcer is a 1. So let's look at the rationale for why that is. When we're completing discharge items, a pressure ulcer that was previously unstageable on admission but later becomes stageable during the patient's stay should be coded based on the stage at which it is first numerically stageable. This pressure ulcer was staged as a 3 during the stay. The ulcer healed. Therefore, it would be considered a stage 3 pressure ulcer healed at discharge. Here's another scenario. Mr. J develops a stage 2 pressure ulcer on his left heel while at the IRF. Unfortunately, he develops pneumonia and is transferred to an acute care hospital for the treatment of his pneumonia. Mr. J returns to the IRF after 5 days with a stage 3 pressure ulcer in the same anatomical location. So the patient, the reason this is a discharge scenario is because the patient is actually being discharged from your IRF. He's going to be gone for 5 days. He comes back for his second admission, and how are we going to code that second admission assessment? In this case, we're going to code it M0300C1. The number of stage 3 pressure ulcers is a 1. And unfortunately, even though the patient had a pressure ulcer in the same location prior to the acute care transfer, because it increased the numerical staging to a 3 during that hospitalization, and he was gone longer than the 3 calendar days, he should be coded as a 1 on the second admission to indicate that the stage 3 pressure ulcer was present in that patient's second admission to the IRF. Here's an interrupted stay scenario. Mrs. K is admitted to the IRF and has no pressure ulcers noted when the admission assessment is completed. She is emergently transferred to acute care for an evaluation and returns to the IRF in less than 3 calendar days, unfortunately with a stage 2 pressure ulcer on her coccyx. this stage 2 pressure ulcer was still present at discharge. How are we going to code this situation on the discharge assessment? This is an interrupted stay scenario, so let's see what the correct answer is. For the discharge assessment coding, we're going to need to include the stage 2 pressure ulcer. So for item M0300B1, the number of stage 2 pressure ulcers is a 1. M0300B2, the number of these stage 2 pressure ulcers that was present on admission is a 0. Remember, when she was admitted to us, she didn't have it. She acquired it during that interrupted stay. M0800A, worsening since admission, stage 2, is 1. Since the stage 2 pressure ulcer acquired during the program interruption was still present at discharge, it would be considered a new pressure ulcer for that IRF stay. Oh, that's too bad. A couple of quick coding tips to keep in mind: that the data reported in the IRF-PAI for Section M are pressure ulcers observed at the time of admission and discharge only. While CMS allows us a 3-day observation period, ideally we want to do our assessments as close to admission and as close to discharge as possible. So you don't need to take the 3 days to do your assessment. In fact, as close to admission and as close to discharge is ideal. Also, clinical assessments performed on patients in IRFs should be completed according to accepted clinical practice and comply with facility policy and state and federal regulations. So although we're making these assessments for the purposes of coding on the IRF-PAI, we all know that we're doing constant skin assessments regularly on all 3 shifts and recording that information in our medical records throughout the entire patient stay. A quick reminder, too, that mucosal pressure ulcers are not staged using the skin pressure ulcer staging system because the anatomical tissue comparison cannot be made. So in other words, any of those mucosal ulcers, like things that you find around the nasogastric tubes or oxygen tubing, urinary catheters, or mucosal ulcers in the oral cavity, should not be coded in the IRF-PAI Section M. And the same would be true on the rare occurrence of a Kennedy ulcer associated with end of life. My final thoughts are 2, and these are mine, and I would recommend that you print out Section M of the manual and leave it available for those staff who are expected to provide assessments to be coded in Section M. Provide training using the manual, use these scenarios here, and there are additional ones that Gina and I showed you on the web page as well for training. While all the items for the quality reporting program are included in every assessment, what we do know is that every patient admitted to your IRF isn't necessarily going to have a pressure ulcer, and folks leaving your IRF aren't going to have a pressure ulcer. So there may be a lot of patients that you're not going to need to code specifically on this item. So having the manual available to people, because it might not be something that they're doing with every admission, although they're going to assess the skin, there may be no pressure ulcers. So it's a good idea to have the manual available. The definitions are there, the nuances of coding, the present on admission, the worsening, all that information is available to them in the training manual. And then the second thing I would highly recommend is don't assume you know the answer as you read down the items. Read the item out loud and really read what you're being asked. Okay? Thanks. I'm going to turn things over to Gina, and she's going to enlighten us on influenza vaccination stuff.
Thanks, Karen. We're now going to review Section O, the influenza vaccination season, and it's hard to believe that in about a month and a half, the season is upon us again. Although this section is not new in this previous year, there are still some questions that are coming up, so we thought it would be a good idea to review this section again. The influenza season begins on July 1st of the current year and ends June 30th of the following year. The influenza vaccination season begins October 1st of the current year and ends March 31st of the following year. Often, facilities will require us to continue beyond the designated flu vaccine. Each area of the country may be affected slightly differently. We in Connecticut saw a real spike at the end of March and into April this previous year, and we continued to offer the vaccine. CMS has clarified that the flu vaccine data is collected year-round, so providers should report flu vaccine data, especially for patients who are in the IRF during the influenza vaccination season. Specifically, any patient who is in the facility 1 or more days from October 1st, or when the vaccine becomes available, and March 31st should have the information documented regardless of the time of year. Only patients that were in the IRF for 1 or more days during the influenza vaccination season between October 1st and March 31st are included in the calculation for the quality measure. It is recommended that IRF should continue to document year-round when a patient has been vaccinated outside the influenza vaccination season. Here is a screenshot of item O0250, influenza vaccine. This item set is completed at discharge. With that being said, at my facility, we ask the patients on admission if they have had the vaccine. If they have not, we offer it during the admission process so that we are not waiting until the day of discharge to give the vaccine, when it could be forgotten during the discharge process. We are now going to review a few different situations of the vaccine being provided during an IRF admission. In this situation, the patient was admitted to the IRF on October 8th, received the vaccination on October 10th, and was discharged home on November 1st. Since the patient was in the facility for 1 or more days during the influenza vaccination season, which again begins October 1st, and received the vaccine for the current season, the information will be reported on the IRF-PAI. In the next scenario, the patient was admitted to the IRF on March 31st, vaccinated on April 1st, and discharged home on April 20th. There are times when vaccinations outside the influenza vaccination season sometimes do count. In this example, the vaccination was given outside the influenza vaccination season, but the patient was admitted during the season, so it counts. Regardless of whether the patient was admitted or discharged during or outside the influenza vaccination season, the information should be reported on the IRF-PAI. In this example, on September 3rd, the patient was vaccinated by their primary care physician. They were then admitted to the IRF on September 15th and discharged home on October 1st. Since the patient was in the facility 1 day during the influenza vaccination season, the information should be reported on the IRF-PAI. This happens frequently in our facility, that patients are admitted within the first few weeks prior to the start of the influenza vaccination season, have already received their vaccine from an outside source, such as a doctor's office or a pharmacy. And we're going to begin to see this very soon here in Connecticut. In Connecticut, we typically see the vaccines being offered beginning in the end of August by pharmacies and doctor's offices. Therefore, this measure, it is important to report the information on the IRF-PAI, regardless of whether the patient was admitted or discharged outside the influenza vaccination season. I will now turn the floor over to Anne, who will discuss the preliminary data analysis and trends seen in the data submissions for new items effective October 1st, 2016.
Great, thank you very much, Gina. So I have been analyzing the National IRF-PAI data. I wanted to provide some feedback about our findings. So first, on behalf of CMS, I would like to thank you very much for all your efforts to collect accurate data. We have found patterns and trends in the data that we expected. Some examples include, first, IRF staff are completing the influenza vaccination items year-round as required by the IRF QRP and as Gina just explained. Second, we are seeing that IRF patients are gaining a good amount of function in the areas of self-care and mobility, which of course is what we expected. And third, an example, we're showing that few patients are developing new or worsened pressure ulcers during the IRF stay. And Karen did a nice job of explaining proper coding for that. So on the next slide, I'd like to review a couple of areas where I did want to reinforce correct coding. And the first topic that I wanted to cover was use of the code 7, patient refused. So in reviewing the data, I did find a few instances in the data where patients were admitted performing an activity and being scored, for example, level 2 through level 6, but at discharge, the patient was coded a code 7, indicating the patient refused at discharge. And I wanted to clarify that coding 7 means that the activity did not occur because the patient refused. And the activity didn't occur means that the patient didn't perform the activity and a helper did not perform the activity for the patient. And that was during the entire 3-day assessment period. So on the slide, we have an example where a therapist would not code 07, patient refused, simply because the patient did not get assessed performing the activity in therapy. And when I said that I found a little bit in the data, I found this for oral hygiene. So theoretically that would mean if 07 is coded for oral hygiene at discharge, that means that the patient refused to brush their teeth or clean their dentures or gums during the entire 3-day assessment period at discharge. So we have an example of proper coding, and so here the example is the therapist is responsible for coding the oral hygiene item. She or he does not assess the activity in therapy during the last 3 days of the patient's stay. So that's for the discharge assessment. So for proper coding, the therapist would interview the patient and nurses to determine the patient's level of independence, to determine what the proper code would be. And if again, the person was brushing their teeth on the nursing care unit, it could be that the patient is independent and can report that they don't need any help with that, or perhaps the therapist might want to ask one of the nurses to determine if assistance was provided. So on the next slide, I wanted to cover another example where code 9, which is not applicable. And for code 9, we really don't expect that to be used a lot. And I just wanted to provide a definition. So code 9, not applicable, indicates the patient did not perform the activity and the helper did not perform the activity for the patient, and the patient or helper did not perform the activity prior to the current illness, exacerbation, or injury. Again, we do not expect this code to be used frequently for most self-care and mobility items. And on the next slide, we have an example of a patient who would be coded 09. And this patient is a person who uses bilateral prosthetics with attached socks and shoes. The patient used both of these prosthetics prior to the acute care and IRF admission. So in this case, for the item putting on and taking off footwear, which is GG0130H, the correct code would be 09, not applicable. And again, the rationale for that is that the person didn't perform the activity and nobody performed the activity for the patient at the time of admission or perhaps discharge. And in addition to that, this was not an activity that the patient did prior to their current admission. So perhaps they were admitted with a new diagnosis of, let's say, a stroke, but they had this prior use of bilateral prosthetics. I did want to also, before I move on, I did want to also mention that we have had some questions come in through the help desk related to code 9, and the particular examples where we have said that code 9 may be used in addition to the example I just described is when For car transfer, if there's no car or a car simulator available to perform practice the activity, so lack of equipment, code 9 may be used. Also, if for walking on uneven surfaces, which is one of the other GG items, if there is bad weather, inclement weather, then a code 9 may be used to indicate that it could not be assessed. So moving to the next slide, 155, I just wanted to highlight that if a patient has an incomplete stay, you may code the self-care and mobility items at discharge as 88, not attempted due to medical condition or safety concern. We certainly know that in some circumstances, a patient may be leaving unexpectedly. It's an unplanned discharge, and the person may be going to acute care, perhaps critical access hospital, and in this instance, you may be able to code an 88 just to indicate that basically the person was had a medical issue at that point in time. So I did want to be sure that you understood how we defined an incomplete stay. And on the IRF-PAI, you will see on slide 156 all of the details. So when we review the IRF-PAI records, these are the particular items that we look at to determine if the patient has experienced an incomplete stay. So the first item that we look at is item 44D, which is discharge destination. And if the patient is coded at discharge that the person was discharged to a short-term general hospital, which is code 2 on 44D, a long-term care hospital, code 63, an inpatient psychiatric facility, code 65, or a critical access hospital, code 66. If the patient is coded as having one of those discharge destinations, that would be classified as an incomplete stay. Also, if the patient is discharged against medical advice, and we would find that by looking at item 41 and seeing a code of 1. If the patient passed away in the IRF, we would look to item 44C and the code response of 0 in that instance. Or finally, we look at length of stay, and so we look at the admission date and the discharge date, and if the length of stay is less than 3 days, we would consider that an incomplete stay. And again, if a patient experienced an incomplete stay, you are able to code the discharge, self-care, and mobility items as 88. Just want to reinforce on the next slide a little bit about Section M. So Karen did an awesome job covering this topic about the pressure ulcers. So just to reinforce, at the time of discharge, the skin assessment items are coded based on the following. So if a pressure ulcer is observed at discharge, determine whether that pressure ulcer was observed at the time of admission. A pressure ulcer that was coded as present on admission on the discharge form. So Karen reviewed that, you would report whether there was a pressure ulcer at discharge, and then there's a follow-up question when there are pressure ulcers at discharge about whether that a pressure ulcer was present upon admission. And so if the pressure ulcer is coded as present upon admission in that section on the discharge section of the IRF-PAI, that refers to a pressure ulcer that has not worsened or that is not new since the time of admission. If the pressure ulcer observed at admission worsens to a higher stage by discharge, it would not be considered as present upon admission when you're coding that discharge item. And again, I think Karen gave some excellent examples. Finally, just a little bit about Section O and influenza. As Gina nicely covered, the influenza vaccination season, again, is October 1 to March 31st. And if the influenza vaccine was not received by a patient, you can code 1, patient not in the facility during this year's influenza vaccine, only if the patient was not in the IRF 1 or more days during the influenza vaccination season. We did see a few instances where people had actually marked this item, but the patient actually had been in the facility 1 or more days between October 1 and March 31st. So I think Gina gave some nice examples reinforcing that, if somebody's admitted, let's say before the influenza vaccination season starts, but let's say the person is discharged on October 1, that patient was indeed in the facility 1 day during the influenza vaccination season. At the end of the season, if somebody is admitted March 31st and discharged, let's say in mid-April, again, that March 31st, that's 1 day in the facility between October 1 and March 31st. So we would count that person when we're calculating the influenza quality measure. We would count that person as being included in the quality measure as being in the facility 1 or more days during the influenza vaccination season. So we have an example here. A patient was admitted to the IRF in June, so June 16th specifically, and discharged June 30th. The patient did not receive the influenza vaccination for the 2016-2017 season. The patient was not in the IRF 1 or more days and did not receive the influenza vaccine prior to being admitted. And so in this case, the code 1 is appropriate. The patient was not in this facility during this year's influenza vaccination season. And with that, I'd like to turn it back to Glenna, who will be helping us to wrap up and do some Q&As. Glenna?
Wow, thank you so much, Ann. I want to thank you and all the other speakers for sharing your knowledge on today's webinar. And before we get started, I'd like to welcome Chris Gross from CMS to the call, who's going to be joining us for the question and answer session. And just to share a little bit about Chris's background, Chris is currently the coordinator for the IRF Quality Reporting Program at CMS. She received her nursing degree from Towson University in Baltimore and a Master's of Science degree in nursing from Stevenson University. She also has a bachelor's degree in political science from the University of Pittsburgh. And prior to joining CMS, Chris worked in the acute care hospital setting as a certified oncology nurse in a variety of positions, including nurse educator in the Department of Nursing Practice, Education, and Research. In her role as nurse educator, her responsibilities included staff education and support in multiple areas of quality improvement, including pressure ulcer prevention and implementation of processes for the prevention of CLABSIs, which is central line associated bloodstream infections, as well as CAUTIs, which are catheter associated urinary tract infections. So thank you, Chris, for joining us on today's webinar. And with that, I'll get started with our first question. Our first question today is, what is the expectation regarding discharge goals for patients who go to acute care unexpectedly? For example, if they're discharged. Then it goes on and says, should the provider code the last known level, or should they code 88 for everything?
Thank you, Glenna, and I would like to thank everybody for attending the webinar today, and also to thank the presenters for taking the time to present this information. Hopefully you all find it helpful. And if I could take another commercial break to also share a reminder before I provide a response. I wanted to remind everybody that the CMS help desks are not secured to receive protected health information or patient-level data with direct identifiers, and we're seeing an uptick in the number of email questions that contain this information. So we just wanted to remind everybody that submitting patient-level data or protected health information may be a violation of your facility's policies and procedures, as well as a violation of the federal HIPAA regulations. So we're asking you to please not submit patient identifiable information such as date of birth, social security numbers, health insurance claim numbers to these addresses. We will not be able to respond to these questions. And again, if you're unsure of whether the information you are submitting is identifiable, please reach out to your institution's privacy officers to help guide you, because we are very, we cannot respond to your questions if it contains this information. So thank you for allowing me the opportunity to share that with you all. But back to Glenna's question, or not Glenna's question, but whoever submitted it, regarding the unexpected discharges. As Ann just kind of alluded to this at the end of the presentation, if a patient has an incomplete stay, the self-care and mobility discharge items can be coded 88, not attempted due to medical condition or safety concern. With regard to the self-care and mobility discharge goals, a minimum of one self-care or mobility goal must be coded per patient stay on the IRF-PAI. For a very short stay that is an incomplete stay, code at least one goal to the best of your ability and using your clinical judgment based on the predicted plan of care for that patient. Back to you, Glenna.
Thank you, Chris. I do have another question here. Let's see. It reads, when a BIMS, and that's BIMS, is not administered because the patient isn't on the rehab unit long enough to test it, what should the provider do? Then it goes on, to avoid transmitting an incomplete IRF-PAI, should we default to staff assessment for mental status, and then would CMS find that acceptable?
Okay, so I think this was also in the slides, but I will summarize. If during the patient's stay, the patient was rarely or never understood due to a medical condition, you would code C0100, should brief interview for mental status, C0200 through C0500 be conducted. Your answer would be 0, no. We then skip to C0900, the staff assessment for mental status, memory, recall ability. You would complete item C0900 by checking all that the patient was normally able to recall. If the BIMS should have been attempted but wasn't, you would code section C as follows. You would indicate that the BIMS should have been conducted by coding C0100 as yes, 1. We then enter dashes for each of the BIMS items, C0200, C0300 A, B, and C, and C0400 A, B, and C. You would then code 0500, the BIMS summary score, as 99. You would code C0600 as 1, yes, and then complete the C0900 staff assessment for mental status. That's it.
Great. Thank you so much. I just want to remind everyone that this webinar is being recorded and it will be posted later on to the CMS YouTube channel, and you will receive an email after it has been posted. Now as we go on to the next question, it says, how would you code the BIMS, and that's again BIMS, if a patient is admitted and discharged to your rehab hospital the same day or within 1 day?
Okay, Glenna, this is essentially the same response that I just provided, but I'll go ahead because I know that we get this question a lot on the help desks or similar questions, so I'll go ahead and repeat it just to make sure everybody catches how to code this properly. If during the patient's stay, the patient was rarely or never understood due to a medical condition, code C0100, should brief interview for mental status be conducted, as 0, no. Skip to C0900, staff assessment for mental status, memory/recall ability, and you would complete C0900 by checking all that the patient was normally able to recall. If the BIMS should have been attempted but was not, you would code section C as follows. Indicate that the BIMS should have been conducted by coding C0100 as yes, 1. Enter dashes for each of the BIMS items, C0200, C0300 A, B, C, C0400 A, B, and C. You would then code C0500, the BIMS summary score, as 99. We'd code C0600 as 1, yes, and then complete the C0900, the staff assessment for mental status.
Okay. So we have another one here, and it starts out with the scenario and then the question. So I'll read the scenario first. The scenario says, we have a patient admitted to acute rehabilitation facility who sustained a fall from a horse, resulting in a back injury leading to acute rehabilitation stay. Then the question asks, does the fall from the horse qualify as a fall for Care Tool J1750? The fall did occur due to an overwhelming external force, but we are uncertain if, in this regard, if the situation does not meet the intention of the question. Great question.
Great. So the definition of a fall is provided on page J1 in Section 4 of the Quality Indicator section of version 1.4 of the training manual, which, as Karen and Gina kind of showed you today earlier in the presentation, it's under the QRP Manuals tab on our IRF QRP webpage. A fall is defined as an unintentional change in position coming to rest on the ground, floor, or onto the next lower surface, such as a bed, a chair, or bedside mat. The definition further states that a fall is not a result of an overwhelming external force, such as a patient pushing another patient. Therefore, in this scenario, the fall from the horse was due to an overwhelming external force and would not meet the definition of a fall for item J1750, History of Falls. That's it, Glenna.
Okay, thank you. We have another question here, similar in that scenario than a question. So it says, in the following example, if a pressure ulcer was determined to progress from a stage 2 to a stage 3 pressure ulcer prior to the placement of a non-removable dressing at discharge, then the pressure ulcer would be considered worsened. The question is, what worsening would this be coded at? Would it be a worsening 3 or worsening unstageable non-removable dressing? It would also be reported as unstageable at discharge as well, correct?
All right, Glenna, in that scenario, if the pressure ulcer declines from a stage 2 to a stage 3 and remains a stage 3 at discharge, it would be coded as stage 3 at discharge and would therefore be considered worsened. In assessing the entire trajectory of this wound, it progressed from a stage 2 to a stage 3, then to unstageable. This is now considered a worsening in status and would be coded as worsened in M0800. It would also be coded at unstageable at the time of discharge.
Okay, our next question. A patient comes in with an unstageable pressure ulcer due to eschar, which was surgically debrided. After debridement, the pressure ulcer became a stage 3 pressure ulcer. It was coded M0300F at admission and prior to debridement. Would this then be a worsening stage 3, M0800B? And should this be coded a stage 3 not present on admission? Let's see, M0300B at discharge.
All right, thanks, Glenna. And I wanted to remind everybody that we will be posting the responses to these questions because I know we get lots of questions on Section M and the staging of pressure ulcers. So in this scenario, if an unstageable pressure ulcer is observed during the admission assessment and during the patient's stay, is debrided and subsequently able to be numerically staged, the pressure ulcer is to be considered not worsened and present on admission when completing the patient's discharge assessment. If, subsequent to the numerical staging, the pressure ulcer further deteriorates and restaged at a higher numerical stage, the pressure ulcer would be considered worsened and not present on admission. In the scenario described, if there are no other pressure ulcers present, admission assessment coding should be M0210, unhealed pressure ulcers as 1, yes, M0300 F1, number of unstageable pressure ulcers due to coverage of wound bed or slough and/or eschar would be 1. If there are no other pressure ulcers, code 0 for all other admission assessment items. If the ulcer after debridement was first staged as a numerical stage 3 ulcer and did not worsen by discharge, and there are no other pressure ulcers, discharge assessment coding should be as follows. M0210, unhealed pressure ulcers equals 1, yes. M0300 C1, current number of stage 3 pressure ulcers would be 1. M0300 C2, number of these stage 3 pressure ulcers that were present on admission would also be 1. If there are no other pressure ulcers at discharge, code all other items, including M0800 A through F, worsening in pressure ulcer status since admission as 1. And that's it.
Thanks, Chris. We have another question. It says, we had a patient admitted with a pressure wound that was classified as unstageable due to deep tissue injury and evolution. Then it says, I guess it was present on admission. Over the course of the rehab stay, the wound became stageable at stage 2. It remained stage 2 until discharge. What is the correct way to report this on the IRF-PAI? Our understanding is that it is not considered a worsening pressure ulcer. Would we list this as an unstageable wound that remained at discharge? Do we list it as unstageable on admission and stage 2 at discharge, M0300B1, but document that it was present on admission, M0300B2? Thank you for your assistance.
All right, Glenna, so another pressure ulcer question, kind of similar scenario, but a different stage. But anyway, so just to I'll definitely provide the response. So, I mean, I think that, you know, once we post these, I think these will be handy to maybe print out so you have handy as examples right at your fingertips. On admission, the coding would be M0210, unhealed pressure ulcers would be 1, yes. M0300 G1, current number of unhealed pressure ulcers that are unstageable due to deep tissue injury would be 1. The remaining pressure ulcer items would be coded 0 if no other pressure ulcers were observed. If the pressure ulcer was unstageable on admission and is able to be numerically staged during the stay, and that stage does not worsen by discharge, code the appropriate stage in M0300, but do not code this ulcer as worsened on the discharge assessment. The pressure ulcer you described is staged as a stage 2 pressure ulcer and does not heal by discharge. Therefore, it would be considered as an unhealed stage 2 pressure ulcer at discharge. If there are no other pressure ulcers, your discharge coding assessment coding would be M0210, unhealed pressure ulcers 1, yes. M0300B1, current number of unhealed stage 2 pressure ulcers would be 1. M0300B2, number of these stage 2 pressure ulcers that were present on admission would be 1. And M0800, worsening in pressure ulcer status since admission, would be 0. That's it.
Wow, Chris, thank you so much. I want to thank everyone for joining us today on the Inpatient Rehabilitation Facility Quality Reporting Program Provider Training. We finished up responding to all the questions we were prepared to answer today. Some of the questions submitted will require some additional research, and as Chris mentioned, a document will be posted that has the answers to all the questions. I again want to thank all of our speakers for joining us this afternoon and sharing your knowledge with our audience. It's very valuable to everyone on the call. And I want everyone to have a great afternoon. Thank you all for joining, and we will post the recording as well as the questions and answers as soon as possible, and everyone will receive a notice as such. Thank you all again, and have a great afternoon. This concludes today's webinar.